So today we will explore frailty and fracture risk in post-transplant patient with role of denosumab as an intervention. Frailty is increasing recognized in the post-transplant population, not just as a feature of aging, but as a syndrome of physiological decline that makes the patient more vulnerable to the poor outcome. Now, it's characterized by reduction in the physiological reserve and resistance to the stressor. That means the body becomes less resilient after the stress of surgery, chronic illness, and immunosuppression. On the right side of the slide, we can see the key symptoms that suggest frailty, such as persistence fatigue, unintentional weight loss, balance problem, fall, instability, issues like incontinence, depression or social isolation, mobility issue, need support and walk, and needing help with daily tasks like feeding, dressing or bathing. These signs are common in post-transplant patients and they indicate that we need to shift our focus from just managing immunosuppression to also addressing functional health and frailty. Now, why does it matters a lot? Because it has a major impact on outcome at every stage of the transplant process. On the waiting list, frail patients are more likely to deteriorate. They have higher rate of hospitalization and at an increased risk of dying before they get an organ. In fact, it has been shown that it predicts the waitlist mortality independent of the disease severity. For example, even a liver patient's MELD score isn't extremely high. If they are frail, the risk of waitlist dropout is significantly elevated. Managing frailty in transplant recipient require multidimensional strategy. This patient often have persistent sarcopenia, chronic inflammation, and immunosuppression related complication, and we need to address and allow us to intervene and possibly reverse poor functional trajectories. One of the most validated tool is the frailty phenotype. It includes 5 objective components that are weight loss, exertion, grip strength, walking speed, physical activity. Even one or two of these components should raise the clinical suspicion of early frailty. If patient had 3 or more of those, they are considered frail and 1 or 2 indicate pre-frailty. Although this is designed for cirrhotic patient, the LFI is gaining traction in transplant circle. It includes grip strength, chest, table, stands, and balance tests that provide reproducible, easy to implement measure even in outpatient nephrology practice. The index is simple, quick, and doesn't need lab support. Now, if you can see the pre-transplant frailty measured by SPPB predicts high fracture risk. And this finding reinforces the need to assess and address frailty early. So, post-transplant patients have higher fracture risk due to pre-existing CKD-MBD, persistent hyperparathyroidism, and immunosuppression regime-related part. Osteoporosis post-transplant is again multifactorial. It includes due to steroid use, CNI, persistent PTH imbalance that lead to trabecular and cortical bone loss. Now, bone remodeling is altered by post-transplant change in vitamin D, FGF23, PTH, phosphorus level, and understanding of this mechanism helps us to target therapy. Persistent hyperparathyroidism contribute to ongoing bone resorption post-transplant, and high PTH is linked with increased fracture risk. Now, immunosuppression disrupts bone remodeling. Say, for example, glucocorticoids suppress osteoblast, CNI reduce bone formation, and mTOR inhibitor impairs bone healing. These agents are major risk factor for post-transplant bone loss, and we need to continue it for life. Now, physical activity is a critical in preserving bone density and strength. In transplant patient, inactivity leads to bone loss due to lack of mechanical stress on osteocytes. This increases the risk of fracture and especially vertebral fracture, and it is worsened by muscle weakness and use of steroid. Osteoporosis is prevalent across all the organ transplant group, but out of this, hip and vertebral fracture are the commonest and associated with very poor outcome. Hence, proactive assessment is critical. So, for monitoring, we need BMD via DEXA scan and lab parameters like PTH, calcium, phosphorus, vitamin D level, that helps us to understand the critical fracture risk assessment. Now, for intervention strategy, nutritional support and physical rehabilitation are cornerstone, especially when initiated pre-transplant. Adequate protein, vitamin D, mineral intake support bone remodeling and muscle strength otherwise. Now understand let's that part. This pre-rehabilitation, just like in any ill patient where rehabilitation is needed, significant impacts the recovery, bone density and overall resilience. So say for example, we need to maintain muscle mass and energy stone, symptom related nutritional issue, let's say for example sodium and fluid restriction. We need to optimize the body weight, need to maintain BMI between 18.5 to 24.9, and finally we need to focus on micronutrient deficiency. These slides contain key reference guideline for diet part. We can see this later on if time permits, but important part is we need to optimize the surgical readiness, we need to reduce the complication, we need to maintain metabolic bone disease part, we need to maintain adequate protein intake initially. Again, initial when catabolic state is there, we need to increase the protein maybe up to 2.5 gram per day. We need to maintain 30 to 35 kilocalorie per kilogram per day. We need to have fluid balance adequately. If heart failure is there, again fluid and salt restriction is the cornerstone. Again, fat part to be controlled. And in lung failure patient, we need to review for salt part. Say for example, with cystic fibrosis patient, again we need to manage it adequately. And finally, nutritional part for wound healing and other portion. Now, again, for kidney patient, as we discussed, sodium and potassium restriction in diet point of view. In liver patient, fat soluble vitamin replacement, that is A, D, E, K. For heart failure patient, again restriction of salt and water. For lung failure patient, fat soluble vitamin replacement. But for pancreas transplant, it's an individualized approach, and we need to correct many deficiency individually. So these are the parts. Now, once the transplant is done, the nutritional focus shifts from repletion to prepare for recovery, healing, and long-term graft protection. Now here, we need to increase the protein intake initially, but long-term again, we need to come on the regular protein intake to 1 gram per kilogram. Need to have initially more calorie for recovery. Again, initially fat could be up to certain extent, but later on, it should be less than 10% of total. And the total energy expenditure later on we need to control, because now patient don't have any catabolic state, so that would be there. Again, hydration, minerals and micronutrient matters a lot. So if say for example patient is having bladder or enteric drainage, having fluid loss, then we need to look after the electrolyte and fluid balance accordingly. Need to check for potassium, phosphorus, magnesium and calcium regularly. We need to increase the sodium intake maybe with cystic fibrosis and lung disease patient. We need to supplement vitamin D, folic acid, and we need to create tailored program for each and every patient for restoring the balance. Now, evidence now support structured rehabilitation program and improving the functional outcome post-transplant beyond bone health, and they reduce the hospitalization. It enhances the quality of life and improves the survival. We need to improve the aerobic capacity, muscle strength. We need to have cycling. We need to prevent muscle atrophy. Need to have resistance training 2 to 3 times a week. We need to have personalized respiratory training, muscle strengthening, post-op pulmonary to prevent post-op pulmonary complication. So with this, if we can see, the bone health is often overlooked in transplant candidate, and we need to review for major risk. And with all the transplant patient, we need to have adequate calcium supplement, vitamin D supplement. As discussed for the exercise part, we need to check for BMD. And if the T-score is less than or equal to -3, we need to have intervention in the form of pharmacological intervention that includes bisphosphonate or with vitamin D supplementation. We need to be proactive for bone protection, because once there is a significant resorption, we don't have anything much to handle. Now, this table comprise all the drugs what are available here: bisphosphonate, denosumab, and a newer agent, romosozumab. But denosumab stands out of its efficacy and safety point of view. in renal patient. So if we can see, Rankel is the final pathway that activates the osteoclast and it promotes the bone resorption. Inhibits Rankel, prevents bone loss, and it's a key target in osteoporosis therapy, especially in high risk group like our transplant patient. It inhibits the Rankel block and osteoclast development and function, denosumab, and this has a direct impact on improving BMD and reducing the fracture rate. Unlike bisphosphonate, denosumab is a monoclonal antibody and its mechanism of safety profile are distinct and it doesn't accumulate in bone or kidney. That is important for kidney transplant patient. And it binds Rankel and inhibit osteoclast development, function and survival. The net effect is significant reduction in bone resorption. Now the standard dose is 60 milligrams subcutaneously every 6 months and it is easy to administer, very few contraindication otherwise. And simultaneously we need to take care for calcium vitamin D supplementation, we need to monitor for calcium level, we need to prevent fall, and we need to examine for osteonecrosis of jaw, and it minutely increase the infection risk and we need to be watchful for that. We can see that denosumab is particularly useful in transplant patient because of its non-renal clearance, and especially useful in transplant recipient where corticosteroid immobility and chronic diseases are prevalent. There is one study where 63 solid organ transplant recipient treated with denosumab and it shows drop in osteoporosis from 75 to just 27%, and that is really important. Here we can see that lead to favorable changes in PTH, beta CTX and osteocalcin level. Denosumab effectively reduce the bone resorption with stabilization of levels that we can see here significantly, and we need to monitor the response ahead. Otherwise, again, this slide shows clear improvement in the T-score after denosumab therapy, and especially in the lumbar spine and femoral neck region. We see over 10% increase in spine and hip BMD post treatment with this. Here we can see the significant drop in osteoporosis prevalence from 75 to 27% as we discussed. Related to some special population like pregnancy and lactation we cannot give. In pediatric, exact dose recommendation are not there. In elderly, no overall difference in safety and efficacy otherwise. As discussed, we can give in renal patient, hepatic patient. Most importantly, in adynamic bone disease, it increases the fracture risk paradoxically. So, before starting it, we need to review the PTH value and it should not be less than 150 otherwise. So, this is the level PTH 150 to 300, ALP should not be very low, and if possible, we can check beta CTX and P1 and P to confirm the active turnover. Now, let's have some otherwise protocols what we can follow. This is the checklist as we discussed. Calcium, vitamin D, PTH should be more than 150, ALP not low, no active infection should be there, and for importantly, reliable follow-up is important. Every 6 monthly this injection to be taken. It is not like that we can stop in between and restart. Otherwise, efficacy will go away. We need to monitor the serum calcium at baseline after 7 to 10 days, then every 1 to 3 monthly to see for hypocalcemia. We need to monitor PTH, phosphorus, vitamin D every 3 to 6 monthly, and we need to reassess BMD every 1 to 2 years. And we need to track signs of hypocalcemia or infection. We need to review this risk factor. We need to checklist. We need to keep checklist for that. Now, if we want to have transition from denosumab to bisphosphonate, then administer bisphosphonate 6 months after the last dose, and we need to ensure calcium and vitamin D support again. Now, we are repeatedly talking about doing DEXA scan, but what we need to see? As a nephrologist, we need to see just T-score or what it is. We need to check for BMD values for lumbar, femoral and total hip part and forearm if used initially. We need to check for T-square and we need to expect improvement or stability more than on 0.5 decline. We need to investigate further, and Z-score for patient less than 50 or male. And we need to check for fracture risk estimate if applicable. Now, we don't just look at the T-score compared to absolute BMD. We need to track trend over the time and correct with the lab result and clinical risk. And if BMD is improving, great. But if it is falling, that's a red flag. We need to check for and we need to intervene for prevention of fracture, and we need to optimize the treatment. So, we need to review to the adherence to the treatment for that, need to check the levels and need to have continuation of the supplement. So generally when to start denosumab with CKD MBD? For that, first of all, we need to have correction of vitamin D, adequate calcium supplement, control of phosphorus, and PTNS should not be very low or very high. Both the things are important. So, to summarize, when to consider the denosumab. So, to start it, the fracture risk is high when the fracture risk is high and the bone turnover is adequate with the T score less than or equal to 2.5. Frailty, fracture risk are there for his fine and risk. Rapid wound loss despite vitamin D or calcium supplement. There is bisphosphonate intolerance or contraindication with GFR less than 30. Persistent steroid use requirement. Obviously, in the case of transplantation, there is secondary hyperparathyroidism, not hypoparathyroidism, with the significant risk of fracture. As we discussed, we aid bone disease is the contraindication for that. Thank you.